please come on the dais. May I request Madam Dr. Anita Borges to please come on the dais. Please give a very big hand for Madam. I request Dr. Avinash Dev sir to please come on the dais. I call upon Dr. Akshay Shah sir to please come on the dais. Dr. Sandeep Gupte sir to please come on the dais. Dr. Dwalkadas Baheti sir to please come on the dais. Dr. Zubair Sheikh sir to please come on the dais. Ms. Revki Rajgopal to please come on the dais. In the name of God, the most beneficent and the most merciful, dignitaries on the dais, off the dais, respected doctors, family physicians, my dear students and dear friends, very, very good afternoon. Namaste, Assalamu Alaikum and Shastrakar. Myself, Dr. Yasmeen Pathan, on behalf of IMPA, Integrated Medical Practitioners Association, wholeheartedly welcome you on this very beautiful afternoon. ये हमारी किस्मत है कि आज हम यहाँ जमा हैं और हमारे साथ मौजूद है डॉक्टर अनीता बोर्जेस मैडम। इस महफिल की जान मैं कहूँ, मैडम ने अपना वक्त निकाला और इस बहुत ही नोबल कॉज के लिए, ब्रेस्ट कैंसर के लिए आज हम यहाँ जमा हो रहे हैं, जो सारी इंसानियत के लिए एक तरीके से एक नासूर बना हुआ है। मैं यहाँ मौजूद सारे फैमिली प्रैक्टिशनर्स का तहे दिल से शुक्रिया अदा करती हूँ कि उन्होंने इतने बिजी शेड्यूल्स में अपने फैमिली कमिटमेंट में यहाँ पर आज जमा हुए हैं। सारे डिग्निटरीज, सारे पैनलिस्ट, दोज हु हैव गिवन देयर टाइम फॉर दिस नोबल कॉज, एंड आई एम आल्सो थ्रिल्ड टू बी द पार्ट ऑफ दिस प्रोग्राम. I really appreciate the joint effort of the Indian Cancer Society along with the SL Raheja and also with the IMPA to come forward with this cause, the breast cancer, the empowering the general practitioners to eradicate the breast cancer, at least not to eradicate, at least to make the aware the people, and also to subside, to clinically decline the cases and early prevention, early diagnosis. हमारे पास जो हमारे पैनलिस्ट हैं उनके लिए आज उनके वेलकम के लिए हमने फूलों को चुना है. ये कहा जाता है, it has been said that after woman the most beautiful thing the Lord has made are flowers. So before handing over the flowers to Dr. Anita Borges madam, madam has told that there is no need to formal introduction of madam. That is big side of madams, but I must say that madam needs no introduction. She is an onco pathologist of a very high repute. Madam has worked in the UK, USA and India. She has retired as a professor of pathology in charge of surgical pathology at the Tata Memorial Hospital, where she has spent over 2 decades. She is the vice chairperson of the Indian Cancer Society. Besides being a very renowned doctor, a very, very humble human being. I call upon Dr. Zubair Sheikh sir to please hand over the flowers to the madam. इनके आने से आ जाती है चेहरे पे रौनक, इनके आने से आ जाती है चेहरे पे रौनक, अब वो समझते हैं कि बीमार का हाल अच्छा है. We have the next speaker with us is Dr. Avinash Dev sir. Sir is a medical oncologist and has over 25 years of experience of immunotherapy, palliative care of the patients with terminal malignancy, breast cancers and different types of cancer treatment. Sir has done many splenectomies, mouth cancers, and stomach or gastric cancer surgeries. Dr. Dev did post-doctoral training at Tata Memorial Hospital. I call upon Dr. Ameen Siddiqui sir, to please felicitate Dr. Avinash Dev sir. फूल यूं ही नहीं खिल जाते साहब, फूल यूं ही नहीं खिल जाते साहब, बीज को दफन होना पड़ता है. Thank you, sir. We have Dr. Akshay Shah, sir, the medical oncologist, over 10 years of experience of head and neck tumor and the cancer treatment, oral cancers and lung cancer treatment, and the breast cancer management, chemotherapy of hematological malignancies and melanomas, and also the chemotherapy of the solid tumors. Dr. Shah has completed his fellowship in the stem cell transplantations from Washington Seattle. His areas of interest include pediatric and hemato-oncology and immunotherapy. I call upon Dr. Intakhab sir to please come forward to felicitate Dr. Akshay sir. Dr. Intakhab sir to Dr. Akshay. Please give a very big hand. We have among us Dr. Sandeep Gupte sir. Sir is an oncoplastic breast surgeon with 15 years of experience in medical and surgical aspects of breast oncology. Sir has competent surgical skill in oncoplastic of breast surgery with sound clinical experience in diagnosis and management of benign and the malignant diseases of the breast. Dr. Gupte has done special training in the AIORT in UK, which is the latest treatment for early breast cancer. Sir has done a lot of free surgeries for poor patients, at least 50 to 80 per year for poor patients. And Sir has done, in fact, for the many camps for the breast awareness programs. I request Dr. Talib Farooqi sir to please forward and felicitate Dr. Sandeep Gupte sir. Dr. Talib Farooqi to Dr. Sandeep Gupte sir. Now we have among us Dr. Baheti sir. Sir is the pain management specialist. Sir is practicing at SL Raheja Hospital. He has undergone training as international scholar at Cleveland Clinic and has done UICC fellowship at Memorial Sloan Kettering Cancer Center. Dr. Baheti has handled several thousand interventional pain management treatment procedures. He has edited and written medical books such as Atlas Interventional Pain Management, Symptom-Oriented Pain Management, among others. He was former professor of NHOD, Bombay Hospital Institute of Medical Sciences, Mumbai. I request Dr. Hanif Thakur sir to please come forward and give a bouquet as a token of respect to Dr. Baheti sir. Now we have Dr. Zubair Sheikh sir among us. He is an integrated medical practitioner since 36 years. Sir has done the LLP and LLM on Human Rights and Consumer Protection Act. He was a part of National Council of Clinical Establishment, Ministry of Health and Family Welfare, Government of India. Dr. Sheikh is currently General Secretary of IMPA. Sir was a ex-vice chairman of CCIM. He has done many selfless work for practitioners and also for the teachers, and always he was there for them at their time of need. I request Dhanashri Madam to please come forward to felicitate Dr. Zubair Sheikh sir with the flowers. जो न लफ्ज़ों में बयां होते हैं, जो न लहजों से अया होते हैं, ऐसे जज्बों की सदाकत के लिए फूल उल्फत की ज़ुबान होते हैं. Now we have, thank you Dhanashri. We have Revati Rajgopal is an onco pathologist. She works with the Indian Cancer Society. She holds a Master's of Philosophy in Psycho-Oncology from Cancer Institute, Chennai. Revati's area of interest are understanding emotional distress, tobacco cessations, handling survivorship issues in the children's INAIA, palliative and end-of-life care, biostatistics, and clinical research methodology. I request Dr. Ishad Momin to please come forward and hand over the flowers to Ms. Revati Rajgopal. Hello, I'm highly privileged to get the flowers from Madam's hand. तो चलिए बात करते हैं आज के प्रोग्राम की. माँ, बहन, बेटी और पत्नी के रूप में औरत जीवन को खूबसूरत बनाती है और औरत को खूबसूरत बनाती है उसकी सेहत. हमारा मोटो है, जब हम बात करेंगे तो बात बनेगी. तो चलिए हम बात करते हैं ब्रेस्ट कैंसर की। अक्टूबर मंथ जो मनाया जाता है एज अ पिंक अक्टूबर फॉर द कैंसर अवेयरनेस मंथ. Breast cancer has ranked as the number one cancer among Indian females with a 25 per 1 lakh women and mortality of 12 per 1 lakh women. It is the world's most prevalent cancer. According to WHO details 2020, 2.3 million women were diagnosed with breast cancer. 6,85,000 deaths were reported in 2020, and at the end of 2020, 7.8 million women were alive. They were diagnosed with cancer. They were fighting with cancer, and it occurs in each and every country. It is the second leading cause of female cancer death, and it has devastating impact on the next generations. When we talk of the woman's death, woman's health, it really impacts on their children, on their families, and it has been found that in 2020, the 4.4 million women died of cancer. Nearly 1 million children were orphaned. Of 25% of them were basically it was just because of the breast cancer death. And just imagine the life of these children after the death of their mother. So, breast cancer is a very important issue. And why it is? Because this cancer can be prevented if we detect it early. That is why we are sitting here. Early detection can prevent, and we have a very high survival rate if it is being detected early. So, family physicians, why? The family physicians plays a very important role, as Madam already discussed in these slides, that he is there from starting to the end of the sessions, and there should be a multidisciplinary approach of the disease. And being a friend, philosopher, and support is also being approach to each and every discipline. So starting with our sessions, we will start with the question answer sessions, and where we are going to ask certain questions to each and every panelist, and then we will discuss. And we will come with the GPs after the discussions over, so that they can come with their questions afterwards. So first of all, we would like to have some, lot of information from them. So the first questions I would like to have with Dr. Zubeshik sir. Sir, as you saw the case discussed in this video, and then do you come across the similar cases in your practice, since you are practicing since 36 years? And what do you do when you come across some patients with such signs of symptoms of breast cancer?
Thank you, madam. Thank you, SL Raheja Hospital and Cancer Society and Dr. Anita Borges for giving us the opportunity to be part of this session and sharing some experience. After seeing this film, I really remember one of my case. Since last 36, I am practicing in the Sandam East. And there were many families. There are many families who are attached to it. There was one family who was with us last 2 decades, but after COVID they are displaced. They again came back to us. Just it was a case of last, I can say, 2.5 years back. She comes, the family was the Sutar family, his husband was carpenter. Mostly in that car, mostly carpenters are staying here. So she told the history of the Dr. Sahab, मुझे थोड़ा सा चलने में सांस लगता है. When I climb Jawahar Nagar में bridge होता है, crossing car is place, I feel like this. And I am feeling very weak, and sometimes I develop chest pain in the right side, sometimes left side also. So I realized this looks pain, it's in my pain anyway. That's why I thought it must be because of anemia or because since he is a 45-year age, we should know the cardiac cause also. So my wife is also practicing along with me. She comes alternate day, I daily practice with me. So I asked her the routine examination. I asked her for the CBC, X-ray chest, and the ECG because he's 45 years. And I asked for the urine and stool both. Urine I asked her because there is why the cause of her anemia. Or there is other stools or what cause of something worms are there in this, because this is a GP level my thinking. So I asked for them. But after report, after 2 days, he come back with the report. The hemoglobin was 8.5. But ECG, X-ray chest, routine urine, everything was normal. But what I then again I might strike, why she is getting pain in the chest, both the side, upper part of the chest. So I asked her, have you observed anything, something there in the pain or something more tenderness, heaviness there in the ब्रेस्ट बोलते नाही साहेब असं काहीच नाही. Then I asked my wife to just have a look her breast if something is there. She found something that hard mass over the breast. Then she realized that it is something, could be something else, anemia could be cause of. Anemia is there. I really go for the further test for hepatitis also. But we thought, so why don't we go for the further test of the urine? So I convinced them because the asking somebody some big test in GP level is very difficult. So because mind goes in double way. कसाला करतात, काय गरज आहे काय करायची, तर द वेरी क्वेश्चन कम टू माइंड. तो आई कन्विंस सर फैमिली को भी भाई आपको ये करने के तो अच्छा रहेगा, आपको तो बीमारी मालूम पड़ेगा आगे क्या होगा क्या है. सो वी आस्क्ड देम फॉर द गो फॉर द मेमोग्राफी टू आशा हॉस्पिटल. They have done and they have come with the opinion there is a small 2 centimeter mass in the upper part of the breast. So I asked my wife again, go and look at this, something gland is there on the right axilla. There was no, but after the report come, they said there is something doubtful about the 2 centimeter mass there in the mammography. So there is no question. So I can keep the patient with me. The thing is that I should refer to the back higher center and critical. So she is being the very poor class, so I cannot ask go for the Nanavati or big hospital. I asked them better you go to Tata Hospital, get done all the tests thoroughly. They went there, they were in the biopsy that are not taken. Now though as soon as the CA word come in the family, whole family dies with the fear and whole family dies because of what express going to be occur with the treatment. तो आधी फैमिली नाम से मत फिर से हो जाती. सो दे हैव कम टू नो कि भाई नाउ देयर इज अ ब्लैक दे विल बी स्पेडिंग दे वांट टू गो फॉर द प्लास्टिकटॉमी. अगेन दे कम टू मी कि डॉक्टर साहब तो छाती निकालने बोल रहे थे, हाउ इज पॉसिबल, क्या वेदर क्लियर इज दैट कि भाई छाती निकाल दिया पेशेंट मर जाएंगे. देयर इज अ क्लियर इन द माइंड. सो आई कॉल हर हस्बैंड ऑल्सो. बघा जर तुमची छाती गेली ना काय घाबरेशन आहे बायको तुमची राहणार. सो दी वे वी हैव टू कन्विंस देम कि भाई कि अगर एक पेशेंट छाती में आ गया है तो अगर आपका एक छेद निकाल दिया तो नथिंग गोइंग टू हैपन टू अदर. सो एट द एंड दे एग्री गो फॉर द mastectomy done. Now she is fine. They are coming with the follow up and they are back to my family. They are still with us and they are following to Tata also. They are following to me also. She is now on the hormonal therapy. So we can how we all GPs here. How we can convince them, how we can counsel them, how we guide them कि because एक छाती निकालने से कुछ नहीं होने वाला. अगर आप एक छाती संभाल कर रखेंगे तो उससे आपकी वाइफ भी चली जाएगी. तो the way you have to treat that is very important. This was a case really I have learned something about how to be connected with the patient, how to can refer the patient to the hospital, how to connect with the senior consultant. Thank you very much.
Thank you, sir. Now the second questions I pass over to everybody. If anybody want to like to answer, what role a family physician can play in the journey of cancer patient? In this case, is specific to breast cancer. So, if anybody would like to talk, can give the answer. What role a family physician can play in the journey of cancer patient?
So I think the family physician has very important role right from beginning, right from diagnosing, and even you can make the diagnosis by clinical examination. I always say when a female patient comes to you, please try to examine her breast, right? And you may surprise to get the breast lump. So that initially you can do that. So in early examination, you can find a small tumor, right? So that's an early cancer rather than patient coming to in a big mass. That's one easy role you can do that. Once you got that, yes, she had some suspicious tumor or something, you can get a basic investigation. You don't have to refer to a specialist, right? You can get a good ultrasound mammography that you can achieve, and then you can find who's the best in that field, right? Because you are the main pillar. You want to refer to the patient to the specialist. You know who's best in that field, right? So again, patient rather than specialist, they believe most of the family patient. Hey, doctor sahab, कौन अच्छा doctor है, right? That trust is important. Again, getting right treatment is important. After surgery also, the decision making. The lot of patient comes to me and say, doctor sahab, पूरा breast निकाल दो. And then they ask me, हमारे डॉक्टर ने बोला है कि पूरा breast निकाल. Then I talk to your family doctor कि see, it's a small tumor, it's not required, we can do a breast. I convince doctor, and then you can convince your patient also. So family patient at every stage in a journey of the cancer patient, right from a diagnosis to the chemotherapy, small side effect, and you can treat at your level also. till the last journey. I think at every step you make a huge difference.
Thank you, sir.
I think the issue of cost was raised. Entire treatment of breast cancer, including chemotherapy, is covered by Ayushman Bharat. So I don't think people who are poor, they can go through the systems and the entire treatment is covered. Everything is covered.
On top of that, I personally, in last 15 years of practice, I haven't denied any single patient for cancer treatment. I do lot of at least 100 surgery in a year free of cost. So I personally do that. And I mean it. So that initiative is required. Lot of CM fund is there, orange scheme is there, right? Ayushman scheme is there. So I think nobody is deprived treatment, but right path is needed where that patient has to be go right. That is more important. You need to understand, and lot of radiation treatments also. Everything is available, but you need to have that where that patient has to be posted for the proper treatment.
Can I just say something? You know, there was something very raised both by Dr. Gupte as well as Dr. Sheikh. When a female patient comes to you, I want to ask family physicians, and there you have Dr. Sheikh, and there are so many of you. It is so simple to just examine the breast. It's not easy to do a vaginal examination. It's not possible in any family practitioner's room, okay? But to do a breast examination and to open the mouth and look for any kind, or particularly in patients who are chewing tobacco and all, to look for lesions in the mouth. And we have 3 important cancers that occur in our country. Okay, one is cancer of the cervix, that's the neck of the womb. Number 2 is oral cancer. For ladies, it is cervix and breast. And for both men and women, it is oral cancer, because so many people chew, smoke, etc. Now, as family physicians, you cannot do vaginal examination, cytology, all of this in your consulting, in your clinic. But certainly you can feel the breast, and certainly you can open the mouth. Okay? However busy you are, at least open the mouth. Okay? Somebody comes to you with cough and cold. If, as Dr. Sheikh said, his wife was there and she examined the breast. But is it possible, that's why I'm asking you, in your clinics, to examine the breasts of women? Because breast cancer, early diagnosis means finding a very small lump. Once the lump is this big, there's nothing much that anybody can do. So can we just ask Yasmeen, whether people do examine breasts? Is it difficult to examine a breast?
Male doctors without female attendant, how can examine?
So that means
we don't have the family female attendant, then we cannot examine.
yeah. So then this is something that we should talk about, because we are talking all the time about.
So I think that's not like prerequisite. You have female relatives.
Relative also,
you can
female relatives,
so you can always
accounting.
Yeah. It's not a mandate thing. So you can take a daughter or some relative and you can explain that we are going to examine the breast. Please stand with us. We are going to examine. I think that ratios will help them to examine. And it happened with me also. We were practitioners. Doctor नहीं है क्या? Then I say आप मेरे बेटे के बराबर हो, आप मेरे भाई के समान हो. We have to be in that communication to make them comfortable. There is more of communication comfort will happen. I think it will done in 5 minutes.
So the basic concern is that the breast examination is very, very important during clinical examinations, and you must do it and convince the patients to go for it rather than the patient is denying, and also we also put ourselves backward. So this is the basic thing.
Self-examination can be taught. Self-examination.
That is very important, the self-examinations. We always say that TLC is important, touch, look and the check. So patients should go for it in front of mirror. She should go and stand and do during bathing and changing the clothes. She should go and do her breast examinations, and every 15 days, every month. But sometimes the small lump, and they don't know how to do. They do it with the fingers and all. We always say that you have to do with the flat of fingers, so that you have to roll on the thing. And also you should see for any abnormalities, any color changes, any dimpling, any discolorations, any abnormal nipple discharges. They should do it regular basis. But that does not happen in Indian society. Being in a gynec practice, I also see that many of my patients are not doing. And maybe the reason is a lack of awareness. We are not, and problem is that we are not reaching the people. So.
Yasmeen, I want to say something about self-examination. Okay, breast self-examination. There are a lot of women in this room, including myself. Breast self-examination always finds some kind of nodularity or some kind of thing in the breast, and that just increases anxiety. Okay, so in answer to your question, Yasmeen, I would not really recommend breast self-examination. In fact, all over the world, it is discouraged, because what it does is it picks up all kinds of sort of necessary kinds of things, and patients go through anxiety, they go through tests, sometimes they're even biopsied for something that is not totally unnecessary. So please, Yasmeen, don't promote breast self-examination. Okay? A physician examination is something quite different. And physician examination, that means somebody who's a doctor, who also, I think, should learn how to examine a breast and not get panicked when there is some vague nodularity. It has to be a defined lump, and therefore all over the world, okay, mammography is not something that you can do in all over. You need, in our kind of society, to get regular mammography, etc., is not there. If somebody wants to do it, they do it above the age of 45, and it has to be done on a regular basis. But that's why I was suggesting that if general practitioners or physicians, whoever, if a woman comes to a physician for some checkup or whatever, if the breasts are examined, that you will probably find earlier lesions than if you had just left it go. So I don't think self-examination is a good. I will ask Dr. Dictate to whether he thinks the same or not.
Actually, we have the same question for the madam. We were about to come to that questions about the
I think it's
self-examination.
an act of observation, right? More you observe, more you train. So take it the other way, right? So if you observe your breast, this is benign nodulity, but the whole purpose was we should not miss a hard lump, something suspicious, right? It's not that you should be very sensitive कि ये भी lump है, cancer हो सकता है, rather than missing a hard lump. So on an average, an Indian woman comes to us in an average size of 3 to 4 centimeters, क्योंकि पता ही नहीं चलता है, right? The whole purpose of examination करके या डेट करके छोटा से छोटा lump पता कर सकते हैं. So I think it's a double-edged sword, but it is. But the whole purpose, we should not miss at least larger masses which is easily palpable.
But what women should be aware of is nipple discharge that is bloody.
So
Okay? Bloody nipple discharge is not normal.
So now, when the madam comes as symptom, I would like to get 3-4 symptoms which everyone should aware. So nipple discharge, the blood stain, right? Blood stain means normally women get either a spontaneous nipple discharge, sometimes they have the bra stain, right? Or sometimes when they press the nipple, if the blood comes, right? Normally blood should not come, right? So either it has to be something pathology that patient has to go to the doctor, number one. A nipple lesion like a milky, green, yellow, white, they are normal variation because our breasts react to the hormones and sometimes duct bacteria, some benign condition can happen, right? But there are different ones. So whenever in doubt, please do see the expert or specialist to rule out whether we are dealing with the cancer. So lump and the nipple discharge. Again, nipple retraction. So nipple retraction, you say a lot of women will have both side nipple retraction, long time. But a recent onset, एक ही साइड में निपल अंदर जा रहा है, स्लीट लाइक, फिश माउथ, राइट? अगर अंदर जा रहा है, that's another important symptoms. So ये 3-4 symptoms बहुत common है, and then obviously lump. ये breast cancer 100 में से 90% cases में 90% इसी form में आने वाला है. So one should be aware to have these symptoms, and we should put on radar. Yes, ऐसे आते हैं. Are we dealing with cancer? Yes. Then the patient has to go to specialist.
Thank you, sir. Thank you, madam. We have the next question to Dr. Zubair Sheikh, sir, but I think since we have come to self-breast examination, we will take the questions before. So, to Dr. Anita, madam, is self-breast examination recommended as per current understanding, it causes
Just
overdiagnosis
gone through
also. We have just gone through it.
So I think we
yeah,
can skip that
madam
question.
is not in favor of that. The next question goes to Dr. Zubeshik sir, family physician. Sir, do you think that there are some barriers in early referral to oncologist? So, if yes, so what are the factors which are being faced in early referral?
There is no one barrier, there are many barriers are there. So the madam raised the question about the examination, why GPs are not doing clinical based on all this. So because of the lack of education, knowledge, and socio-economic conditions are being bad in slum area where we practice. It's become very difficult to convince them for certain thing, go this test. And another thing was that now कि नॉलेज नहीं है तो बस ये पता नहीं होती क्या करना है क्या नहीं करना है. अगर नॉलेज आ भी जाती है तो fear of question of the finance always arises there. As I said just now, here the Ayushman Bharat is dealing with all the free of cost. Definitely we all convey message to our all members. In such cases, definitely refer to the Ayushman Bharat and get to treat our family, because one family member dies, whole family is missed out. We lose our family because our livelihood is bad depending on the one patient family. So we always think that patient should not die. तो any sometimes something goes wrong also the patient blame us कि आपने पहले क्यों नहीं बताया. So knowledge of the thing is very important, and awareness program, as we are celebrating the month of October is the breast cancer awareness program, and madam has put our pink ribbon is there. So we are also making the awareness. We want to make aware our practitioner, they should learn and they should go with the full knowledge to then guide the others. So we can say there is a lot of misconcept कि भाई एक breast निकाल दिया तो कैंसर बड़ा बढ़ जाएगा. Another thing, if I lose my one breast, my husband may not divorce me. Because it's very important now. The concept is there in Burma. But there is another story. What I learned from the Anita Borges. Must have heard about the ladies. A very big story about she removed her both breasts because her family history was about the grandmother and grandmother all died because of cancer. So yes, she has gone so forward and given message कि अगर आपका breast नहीं है, there's something like that, you will lose your family. Everything is there. So we should make aware of all our patients कि breast is definitely important, but not at the cost of life. Thank you.
Thank you, sir. We always talk about the gene mutation as sir has reason this thing. And a lot of studies are going on into gene mutations and studies, and they are going for the preventive mastectomies for the same. I still remember a case, if they allow, the panelists allow me to talk. Patients of mine, I was in internships, and the patient of 40 years, she came with a ghabrahat and uneasiness in the chest. So the senior doctor asked to get the ECG done, and we were very enthusiastic to take the ECGs and all. So I was also standing, and when they were putting the lids, I saw the breast, I saw that something is abnormal. So I just touched and I found the whole breast is just rock, it was just a stony hard. The one-sided breast was stony hard, and I was very shocked. She was unmarried. She was living with her brother. And I said, you have a lump and this type of, for how many years you have? She said, I have for so many years. I said, did you talk with somebody? She said, no, I never had a talk because I was very shy to talk, But I had something in my breast. She was unmarried and, So she was having the lump, it was gone, and then they came out that the uneasiness was because of the metastasis. The patient was sent for PET scan and then to onco physicians and all. But, the diagnosis came at that point when we were doing the ECGs. So that way we also see the patient, that the same patient we have seen here with metastasis in the spine, this melanoma has come with that. So the patient can present with that type of things because of the shyness, because of the unawareness. So we have the next question to Dr. Sandeep Bipte sir. Should we refer a woman who has lump immediately to an oncologist?
So if the patients come to you as a family physician and we found that there is a lump, right? So at least basic test you can get from good ultrasound or mammography, you can get that, and based on the report you can decide if it is suspicious. Yes, the patient can go to the breast oncologist or surgeon where you can get the biopsy and proper treatment. Because what happened, once you see the lump, it's desired to refer to the surgeon, and 30% cases thought they give lumpectomy done earlier, then cancer, and then come back. So they invested money in that, right? So decide based on the report, and then you can refer the patient. Rather than not every patient requires surgery, right? So biopsy also plays very important role before surgery. Make sure that you are dealing with what type of lump.
Thank you, sir. The next question goes to the family physician, Dr. Zubeshik, sir. Do you recommend breast cancer screening to your patient? Screening to your patients? Which test do you ask for?
Of course, we ask for the clinical breast examination, mammography we ask, and ultrasound also, biopsy, obviously, all the things are available.
Madam, I just have a question that the mammography they say for every 2 years or 1 year, what is the basic recommendation, madam? And they say after 40, 45 days, there are a lot of, I see the contradictions into the mammography, how much the subject will move.
The reason that people say after the age of 45 is because a young breast has got a lot of breast tissue, which has, the distinction on ultrasound or mammography, whichever, between normal breast tissue and the cancer is not easy to make because the breast is very dense. As the woman ages, breast tissue shrinks and fat, accumulates in the breast. So an older breast has more fat and less breast tissue. And in such a situation, you can see a cancer or a lump easily on that's why getting a scan done in a very dense breast, which we assume is below the age of 45, doesn't make much sense because you're doing a mammography and it's not very efficient at looking at. So if you're wanting to do a mammography in a screening sort of way, okay, there's mammography can be done for diagnosis, like what Dr. Sheikh said. This woman who was anemic, and then they discovered that she had. That was a diagnostic mammography. But when we're talking about screening, it's the same mammogram. But here, the woman is asymptomatic. So remember one thing about screening. Screening is you do it in an asymptomatic person. So somebody has no symptoms at all. If somebody finds a lump, then she's symptomatic. Then you go to, mammography is diagnostic. You go to find out where is the lump, what are the characteristics of the lump, etc., etc. But if she's absolutely asymptomatic, no lump, nothing, and she just wants to be, screened from, I want to be safe, I don't want to suddenly find, So then mammography is one method of screening. But again, I have to tell you that just having a mammographic machine is not enough. The person who is actually doing meaning once the pictures come, reading that mammogram is a very, very, it needs experience because small things, can be missed. Lumps I'm talking about, but there are other things that they have to notice, calcifications, some kind of. Now all of that requires experience. So somebody comes and just says mammography control, but this is something that the general public cannot even evaluate. Okay, but if you're going to do it after the age of 45, do it after every 2 years. So once in 2 years. That is the recommendation. But I don't think it really happens like that in this country. Only people who are very, very conscious of their health, they go for mammography. In government recommended screening for breast cancer is only physician breast examination. Mammography for an all India screening program is not mammography. But you want to go and have mammography done, anybody, that's fine. But just don't do it once. You have to do it regularly every 2 years. Yes?
Thank you, madam. We have a next question for Dr. Sandeep Gupte, sir. So when to send a patient for mammography and FNEC or biopsy?
I think the mammography already answered it. So rather now early days the FNEC people was doing right, but now FNEC is evolution completely and we're going for biopsy. The two reasons: one, when we can get the proper diagnosis and we can get the nature of the disease, what type of cancer it is. We got, if it is cancer, we got an ER, we got a biology of disease. So it's good for treatment. So nowadays, most of the cases we go for biopsy. Sometime in FNEC, it may look like cancer, right? and you land up in any surgery and turn out to be benign, right? That fallacy can be easily avoided. So once you find a solid lump, make sure that you should get a core biopsy, and that too we are doing nowadays a sonography guided, right? And large palpable one can do the biopsy, but in a small tumor to get a proper diagnosis, sonography guided biopsy is recommended.
Thank you, sir. And FNSC also can be falsely negative. That could be a very dangerous thing. We have the next question to Dr. Anita, madam. Madam, what are the preventive measures for the breast cancers? What the age group for screening?
I don't think that breast cancer can be prevented as such. Breast cancer is a lifestyle, is quite often a lifestyle related disease, in the sense that just think, 20 years ago, maybe even less than that, cervical cancer, that is of the cervix, was the #1 cancer in females. Now cervical cancer is falling, okay, and breast cancer is rising. Why? Because we have changed in the urban areas, we have changed our lifestyle. Okay? Women have become empowered. Women have become, sort of contributing to the family income. So what do? They get married later in life. When you get married later in life, you have less children. Now that brings down you live in better environment, you have access to clean water, to clean bathing rooms, etc. So what happens? Your genital hygiene is good, so you don't get cervical cancer. But on the other hand, your lifestyle, you're postponing your marriage, you're postponing the number of children that you have, okay? And also you start to change your diet. You start eating a lot of rubbish, like McDonald's and all this kind of stuff. I mean, tell me, when I was growing up, there was none of this McDonald's and all this. Now the temptations are there to change your lifestyle and eat this kind of fast food, which is not very conducive. So your lifestyle changes. People need to understand that this is, as far as prevention is concerned, since there is no way you can actually prevent it, unless like, Angelina Jolie or something like that. You know that you have, there is a family history of breast cancer, and then you think, I don't want to get breast cancer, so I take off both my breasts. Okay? That's the only way you can prevent breast cancer, to take off your breasts. There is no other real way of preventing breast cancer, but you can do what is called early diagnosis. And we discussed that, no mastectomy, this mammography, physician breast examination, but lead as far as possible a healthy lifestyle. Now you cannot say that I will get married early, I will have children early. I mean, this is progress, and women are becoming empowered. They don't want to go back to that age where at the age of 18 and 19 and 20 they are getting married and having children. So some risks we have to accept. It's the same risk, If I don't want to be knocked down by a car, then I should go and live in a village where there are no cars. But is that sensible for me to do? No, I take the risk of living in a city and I'm careful. So this is what I'm saying, be careful. Go and do, when in the street you say look left, look right, and then cross the road. Similarly, as far as breast cancer is concerned, go and if you want to do self-examination, or go and get a physician to examine, or get a mammography done. That's what I'm telling you. You cannot get away from breast cancer. The lifestyle that you lead is contributing to it, but it doesn't take away the risk completely.
Thank you, madam. So, madam told that the prevention there are risk factors. As we say that there are a lot of alcohol consumption we are seeing nowadays with the females, and also the tobacco, which has gone insane in the earlier days. And that also is a contributing factor for causing the early cancers, breast cancers in the women. Increased reproductive age, late menopause can also be the cause, because the women are more prone for the estrogen and progesterone hormones throughout his reproductive life. She is more prone to have the breast changes, which can come across to the cancers in any time of the life. The next question goes to Dr. Avinash Dev, sir. Sir, we are talking about the survival of the patients and also about the stage 4 patients. What is the survival rate and how will you rate that?
Actually, breast cancer is not one disease. So there are three types of the presentation showed. There's something called hormone receptor positive, there's something HER2 positive, and there's something triple negative. I think the worst rates which we have is by triple negative. And I think yet we have patients who go on for 3 to 4 years with triple negative also. There's the option of treating immunotherapy. Though it's become cheaper, it's very expensive. And that has changed the outcome triple negative. When you look at the other two types, the survival is much better. For example, in hormone responsive breast cancers, the kind of drugs we have now, they give a long survival and we have many options. So you have almost 3 lines of hormone treatment before you go to chemotherapy, which you have many options there. And a few months ago, these drugs have become generic now. So they were patented till about last year, but now they're generic and the costs are really high. In what you call HER2 positive breast cancer, again, the survival can be quite long. I had one patient who came with disseminate cancer, the entire chest was a tumor, and the disease was controlled almost for 6 years. Some drugs which are there are generic, others will become generic by next year. So again, we will have a prolonged control. And apart from this, I mean, there was some data which was there from the time when these treatments are not available. So if you treat you treat all cancers with chemotherapy, there's about a 5 to 10% 15-year survival. So there will be some patients who will respond very well and they'll stay responded for a very long time. There will be some patients who will continue to relapse at short intervals. So it's a very, very heterogeneous disease, but with the options available and with the kind of drugs which we have now, even the worst of disease, the control is possible and a quality of life is possible for them.
Suppose you don't have metastases on the and patient presents with a lump only in the breast or perhaps with an axillary lymph. What you were talking about survival is for metastatic breast cancer and systemic metastasis.
Then I think if you're looking at small nodes, I mean typically 2 centimeters, 1 centimeter, we are almost going at almost 80 to 90% tenure survivals. And many of these patients are cured. And that's why it's important to pick it up early. Because if you're picking up early, there's a window for cure. And it may go as high as 90%. I mean, in the Western societies, they do regular mammographies. They pick up small tumors which are 1 centimeter or less. We are looking at almost 90% tenure, and many of these people will be cured.
Thank you, sir. My next question for Dr. Akshay, sir. What should a family physician know about interpretation of biopsy report and the importance of receptor study